Discussion 3, High Content Imaging Applications to Tissue Engineering. I'm Kyle Quinn, Assistant Professor at the University of Arkansas, and I'll be one of the moderators for this session. It's my great pleasure to introduce our first speaker of the session, Dr. Melissa Skala, who's one of my favorite people to run into at biomedical conferences. Melissa is a professor of biomedical engineering at the University of Wisconsin-Madison and runs her lab at the Morgridge Institute for Research there. Over the years, she's had previous stops at Wisconsin, Duke, and Vanderbilt. And she's one of the pioneers in developing and applying label-free quantitative imaging tools to assess cell metabolism. She's been doing some exciting work in using these tools with patient-derived cancer organoids, which has some important implications for drug development and clinical planning. So in contrast to much of the work that we've seen at this conference, Melissa takes on this challenging task of quantitative imaging using only autofluorescence and other endogenous sources of contrast. Recently, she's extended this work to look at immune cell activation, but I should let Melissa tell you about these things, so let's cue up her presentation.
Hello, my name is Melissa Skala, and I'm an investigator at the Morgridge Institute for Research, also a professor of biomedical engineering at the University of Wisconsin-Madison. Today I'm going to talk about metabolic imaging of cellular heterogeneity and patient-derived cancer organoids. So when I think about cancer, I think about the single-cell heterogeneity and how that can affect treatment response and tumor growth. And this video here is a simulation that nicely encompasses that idea. So each of these dots is representing a different cell, and each color represents a different phenotype of that cell. So that could be surface marker expression, metabolism, proliferation rate, anything. And so what we're going to do here is see how the tumor grows and how these subclones of tumor cells grow and how they respond to treatment. So here we have the tumor growing over, several days here. And now we have treatment, which, could be anything, radiation, chemotherapy, targeted therapy. And you see that this treatment is very effective at reducing the number of cells to very few compared to what we had at the beginning. But now what you see is this sort of subclonal growth. So there's a few types of cells that are thriving with this treatment. So the treatment is still happening, but the cells are still growing, and they're actually outgrowing what they were contributing to the original tumor. So this is what we think about when we think about single cell heterogeneity in cancer. And this is important because we see it in the clinic. We see people who initially respond and have almost undetectable cancer. And then after prolonged treatment, we see a new type of tumor growing that is more treatment resistant, more lethal, more aggressive. And what we've done here is select for a subpopulation of cells that is perhaps more lethal than the original tumor cells that were providing some portion of selective pressures in the tumor. So this nicely illustrates the idea that heterogeneity between tumor cells contributes to treatment resistance. And currently we don't consider this in clinical treatment, and mostly this is because we don't have the tools to do so. So we look at things like CT or MRI to understand how a tumor is growing or shrinking, but we don't think about single cell heterogeneity. So what I'd like to do is use microscopy to address this issue, because microscopy, as you know, is really great for single cell resolution. We're not doing it in vivo in humans, except for some surface cancers. So we have to be a little more creative about how we're going to assess single cell heterogeneity using microscopy. So what we do is use tumor organoids, and these are growing in popularity because they're a great model system to measure single cell response within a patient matched sample. So what we do is we get a biopsy or a surgical sample from a patient, and we just take the tissue and we mechanically dissociate it. That means we cut it up with scissors, and then we embed it in a 3D collagen matrix. So it's kind of like a jello, looking thing, gelatin kind of. And then we put media over the top. So what we're trying to do here is mimic the body and try to fool these tumor cells into behaving as they would in the body. And the benefit here for us as microscopists is that these are small things. So these tumor organoids are only about 200, sometimes they get bigger, a few hundred microns in diameter. So we can assess them with things like 2-photon microscopy, and we can image all the way through the tumor organoids in this way. And so this advancements in tumor organoids have been really beneficial for us in assessing single cell heterogeneity. And previous groups have really done a fantastic job characterizing these tumor organoids. It's a popular area of study. And they've shown that genetic expression levels in the organoids closely mimics the host tumor. The heterogeneity in cell types of the host tumor maintained in the organoids. And there are some other studies looking at functional imaging within these tumor organoids. And I'm happy to see this is a growing area of investigation, because I think it's a great way that we can contribute as imaging experts to this great need in oncology. So in my lab, we're trying to do things sort of on two ends of the spectrum. We're thinking about clinical impact. So we want to develop high throughput drug screening technologies on a single patient level so that we can inform clinical treatment decisions, because as you know, each tumor is different, each patient responds differently to treatment. So these matched tumor organoids are a nice way to assess that before we actually treat the patient. But we work on some tumors that don't have very good drug treatment options, like pancreatic cancer. So we want to also use the same system of using patient-derived samples to really understand what drugs we should go after in clinical trials later on. So what we're doing is obtaining a tumor biopsy or surgical sample, and we replicate the sample as much as possible into as many wells as we are able to, given the size of the sample and its viability. And then we perform optical metabolic imaging, which I'll talk about later, but it is a 2-photon autofluorescence imaging technique that we use to assess single cell response to treatment. And then we quantify the single cell response to treatment and use some population density modeling to understand how heterogeneity might contribute to treatment response or resistance. And from this, we're hoping we can identify an optimal treatment regimen that really improves the life of the patient. And if not improves the life of the patient in this particular context, we're also testing many different potential candidates for clinical trials so that we can get those to patients as soon as possible. So I mentioned we're looking at metabolic response in the tumor cells. And so, you could measure anything you want to understand treatment response in tumor organoids. And we chose metabolism because we know that metabolism is one of the early changes in the cell in response to treatment. So this gives us an early measure of drug efficacy. We also know that cell metabolism can capture non-genetic adaptation in drug resistance. It's not very well captured by current techniques, so it offers some ability to fill a niche that's currently not met. And we know that within the tumor, there's selective pressures that create metabolic microenvironments that really do contribute to tumor heterogeneity. And so we can capture that with our techniques. So what exactly are we measuring? We're measuring autofluorescence from two metabolic coenzymes. So NADH and FAD are ubiquitous. We even find them in bacteria. So they're very common electron donor and acceptor. They're involved, for example, NADH is involved in greater than 300 reactions in the cell, both in the cytosol and in the mitochondria. And we're just highlighting a few here to give you an idea of what we're looking at. So first of all, NADH and NADPH are spectrally overlapping, and they have overlapping fluorescent properties. So we refer to them collectively as NADPH. And FAD and FMN are also closely related in their spectral properties. So this is a combination of both of those molecules. So you can see we produce, NADH and consume NADH in various metabolic reactions. And what we do is take the ratio of NADH to FAD and call this the optical redox ratio, which provides us information on how oxidized or reduced the overall cell is. And this has become very useful in many different studies for measuring whether a tumor is malignant or not, whether it's aggressive or not, and we use it to measure drug response. We're also measuring the fluorescence lifetime of these molecules. So that's the time that the molecule is in the excited state before decaying back down to the ground state. And this is useful because NADH and FAD have two very distinct conformations. So for example, NADH, when it's free, it folds up on itself like this. And when it binds to a protein, it extends, and that creates two very distinct lifetimes due to some self-quenching here. So the free NADH has a short lifetime, the protein-bound NADH has a long lifetime. And the converse is true for FAD. So when we measure the fluorescence lifetime, we're really measuring the pools of NADH or FAD that are in a free or a protein-bound state. And this gives us an idea of binding activity of these molecules. And it's very sensitive, again, to malignancy and drug response. So as I mentioned before, we're using 2-photon microscopy, and we're using time-correlated single photon counting. So we're building up this decay curve for each pixel in the image, and then we fit this decay curve to a 2 exponential model because we're looking at both the free and bound forms of NADH and FAD. We also have this instrument response function that we first deconvolve with the measured values to obtain our decay curves. So I'm going to mostly talk about the mean lifetime today, and that's the weighted average of the short and the long lifetime. So this alpha value is just the contribution of the free NADH, or the alpha 2 is the contribution of the protein-bound NADH. And that's what we're measuring in our experiments. We're also doing single cell analysis. So again, this is autofluorescence measurements. So we had to develop our own pipelines for segmenting cells, specifically cell cytoplasm. So we're segmenting out the nucleus and keeping the cytosol and mitochondria all together. And through this, we can then graph basically the number of cells and an autofluorescence variable, and then start to ask questions about the heterogeneity in those populations. So I'm actually going to breeze over a bunch of our work in just one slide here. We've done a bunch of work in vivo and in tumor organoids derived from both animal models and patients. And we've shown that we can combine all of these variables in a way that makes it a little easier to understand what the cell is thinking. So I already told you about the redox ratio and the lifetimes of NADH and FAD, which have a 2 exponential decay. We just did this empirically. So this is from a multivariate analysis of variance. We knew which cells were responsive to treatment and which weren't across multiple model systems. And we found that basically a linear combination of the redox ratio, NADH mean lifetime and FAD mean lifetime, all mean normalized, with the -1 coefficient here for the FAD, provided us with really sensitive and specific information on cell response to treatment. So biochemically, this is not as meaningful as each variable on its own because it's composite, but within this, we know that we're looking at the relative amounts of electron donor and acceptor in a cell and the enzyme activity of NADH and FAD. And we define this OMI index to increase or not change in cells that are resistant to treatment, or to decrease in cells that are responsive to treatment. So we showed that depending on the model system, somewhere around 1 to 3 days post-treatment, we're very sensitive to treatment response in organoids that predicts later in vivo response in mouse models and in patient samples. So for the clinical translation, I really want to highlight my clinical collaborators, Dusty Deming and Mark Burkhardt, and this fantastic program they've made, the Precision Medicine Molecular Tumor Board. So this is a Wisconsin service. It's supported by the Wisconsin state government, and it is a free referral service. So you can refer yourself, or any of your doctors can refer you. And what you get is a free genomic report. So we need a biopsy or surgical sample, and we can look for common genetic alterations. And then the smart people on the review board, like Dusty and Mark, get together and look at this genomic report and then make a recommendation. So they might find that you have a pretty typical genomic report and you should go on standard treatment. They might find you have a particular mutation that makes you a really good candidate for a clinical trial. And they might find you have a mutation that isn't common for your cancer, but is common in other cancers, so you might use a different cancer treatment. So we have tapped into this Precision Medicine Molecular Tumor Board, and some of the samples in which we get a genomic report, we also grow tumor organoids, and we ask questions about whether we can predict which treatment is best and what alternative treatments might be best by testing those treatments directly on the patient samples. So I'm going to talk first about some pancreatic cancer studies we've done, and then a little bit about some breast cancer studies we've done, but we have ongoing studies in multiple cancer types. So for example, we have here a pancreatic cancer patient, and the control is just given vehicle, and the G+F is gemcitabine and FOLFIRINOX. So that's a common treatment for pancreatic cancer. And these are both organoids from a patient, the same patient, so they're matched. And what we found is that this patient would respond well to the combination treatment. And they have a nice sort of homogeneous distribution of cellular metabolism in the control samples, and a nice homogeneous distribution of cell metabolism in the treated samples. So this to us looks like maybe someone who would respond well to treatment. Here is another patient, patient 8. They were prescribed 5-FU treatment. So I should mention the first patient was prescribed this gemcitabine and FOLFIRINOX treatment. Same story here. We have the control cells and the treated cells in 3D culture. So all the cells we're looking at here are tumor cells. And what we see is a very low difference between the OMI index in the control and the 5-FU treated organoids. And this glasses delta is just a measure of mean differences with respect to standard deviation. So it's a little more strict than what you'll find from a t-test. And what we see in the control samples is that this is a heterogeneous response, even a heterogeneous distribution of metabolic activity, even without any treatment. And when we do treat the patient sample, we see a very similar heterogeneous distribution that has not changed with treatment. So we would predict that this person would not do well on 5-FU treatment, just based on the mean change in the OMI index and on the heterogeneity of those changes. So when we started these studies, we thought, gee, these little squiggles of population density modeling here are really useful for understanding what's happening in the patient, and perhaps we should quantify how these squiggles change with patients. Oh, I forgot to mention, we also measure, standard measures of response like Ki-67, which is an immunohistochemical measure of proliferation, and cleaved caspase-3, which is also immunohistochemistry of apoptosis. And we see that we have good correlation between, some of these, like Ki-67, but it's not perfect. And so we're measuring something related to proliferation, but not exactly the same, and not exactly the same as apoptosis. So it's a useful measure, but different from what we're used to seeing. So the heterogeneity index is something we developed to try to understand the single cell metabolic response that we were observing in our patient-derived samples. And we actually developed this from the Shannon Diversity Index, which is used in information theory. It's used in ecology to understand diversity in an ecosystem. We modified it a little bit so that it could characterize the changes we saw in the samples we were looking at. So really, we're just looking at the number of subpopulations in the sample. So one with one subpopulation is more homogeneous than 2 subpopulations. Equality in subpopulations means it's more heterogeneous instead of, like, say, a minority, very small subpopulation and a majority, very large subpopulation. Greater separation between these subpopulations also indicates greater heterogeneity. And then we also included a standard deviation measure so that we could define how broad these subpopulations are. So overall, we define this as a weighted heterogeneity index because we decided to add this sort of standard deviation at the end. So it's a little different than the Shannon Diversity Index, but it provides similar information. So what we found in this initial study of just, let's see, 1, 2, 3, 4, 5, 6, 7 patients is that we had some who responded much better to treatment than others. So the ones we predicted to respond are in blue. Their actual response is indicated at the end here. In red are those that we predicted would not respond well to the treatment they were prescribed. So we just arbitrarily, more or less, drew this line here at 12 months, which discriminates those patients that we predicted would respond versus those patients we predicted would not respond. There's many ways to design this study, and this is very small. So we defined whether or not these patients would respond or not based on 2 things. This glasses index delta, which I'm showing here, the definition again is the OMI index for the control minus that of the drug treated sample divided by the standard deviation of control. So we tested multiple treatments, but here we're just talking about the treatment that the patient was actually given, and then we follow them up over time. That's what this swimmer plot's about. So you can see that the predicted non-responders had a much lower change in their OMI index compared to those we predicted would respond to treatment. So that checks out with how we define our OMI index in our previous studies. We also quantified the weighted heterogeneity index, which I define here again for you. And we find that those patients who responded to treatments, they might have had very heterogeneous tumors to begin with, but those got much less heterogeneous with with treatment. Whereas these patients who had very poor response had high heterogeneity that did not change much with treatment, or low heterogeneity that then increased with treatment. So this is a first study, of course, and we're looking at more patients through the Precision Medicine Molecular Tumor Board to see if this holds. I mentioned only response to the tumor cells so far. So organoids are great in that they also have other cell types. So we see stellate cells or fibroblasts growing in the culture too, and especially adhering to the glass. So that's what we're seeing here are the fibroblasts in these patient-derived samples. So we quantified response for these cells as well in the hopes of finding drugs that might target these important cells within pancreatic cancer. So actually, stellate cells and fibroblasts can make up as much as 80 or 90% of the tumor mass. So you can see here some of these fibroblasts are responding very well to the treatment in a homogeneous way. Some others are not responding very well and are very heterogeneous. And then others are responding well also in a homogeneous way. So you can see that we have the middle patient here who had the least response in their fibroblasts had the earliest recurrence, whereas these two, which responded well to their treatment, had longer life. So that so far was just talking about pancreatic cancer, but we also have some studies in breast cancer. So I wanted to show just one sort of representative slide from breast cancer because this study relied only on core needle biopsies, which are very small samples, but they're valuable samples because the core needle biopsies are taken before neoadjuvant treatment. So then we have a very well-defined treatment window of neoadjuvant and then surgery. So we can look at exactly how those patients respond to treatment. So here we're using different drugs because we are looking at breast cancer. Paclitaxel on its own with cyclophosphamide and with cyclophosphamide and doxorubicin. So we looked at a few other drugs depending on what the patient was expressing. For example, if they had a HER2 positive tumor, we gave them trastuzumab. But you can see here very clearly that the combination treatment created the largest changes in OMI Index in the patient-derived tumor organoids. If we just look at a couple of examples, this is one patient who had a very good response to their prescribed treatment in their organoids, and it was a very homogeneous response. And at the time of surgery, the pathologist indicated that this patient had minimum residual disease. That agrees well with these large changes we saw in their organoids. Here we have another patient who actually had extensive residual disease at the time of surgery. When we looked at their tumor organoids for their prescribed treatment, they had smaller Glasses delta, so smaller change in OMI index with treatment, and they had a more heterogeneous tumor before treatment. So again, this is only a few patients and we're trying to put all this data together, but that gives us an indication of what might be the path for breast cancer assessments, especially in the neoadjuvant setting. So I just mentioned today a few patients from pancreatic cancer and breast cancer, and I really only talked about the clinical studies. We have many more studies in mouse models of cancer too. So we're trying to reconcile what's happening in patients with what we see in mice, and we're trying to understand what particular parameters are most predictive of treatment response. We're looking at, as well at oral cancer, neuroendocrine tumors, and colon cancers. And this is all again through the Precision Medicine Molecular Tumor Board at the University of Wisconsin-Madison. So today I talked a little bit about single cell adaptation in cancer, and hopefully I've convinced you that this is an important feature to look at, both preclinically for drug development and clinically for informing patient treatment decisions. And we looked at a few examples of patient-matched organoids in both pancreatic cancer and breast cancer to understand whether cellular metabolic heterogeneity can explain some of our treatment response in the clinic. And we're hoping that we could use this method to predict patient treatment response and develop more effective therapies for patients. I'd like to thank especially Joe Sherrick, who did all the work in the breast cancer and pancreatic cancer. My collaborators, of course, Dusty Deming, Mark Burkhardt, Sherry Pash, and all the wonderful people I work with at the University of Wisconsin. And I'm happy to take any questions. And thank you. Hi, Kyle. How are you?
Hi. Well, thank you, Melissa, for that talk. And let's move on to the Q&A portion. So we have a question about image analysis. We can maybe start with that. For segmentation of single nuclei in the organoid structure, you mentioned that you're using AI. Could you talk a little bit more about this in detail?
Yeah, I actually, we're not really using AI. So we're using Cell Profiler, which is a freeware, out of the Broad Institute. And it is, identifying an object, which is the nuclei. And then once we get to the nuclei, it propagates out until it identifies the cell border. So it's not AI, but we are working on more methods because it isn't perfect and we have to go in there and fix stuff often. So we're also looking at convolutional neural networks, and we're getting those to work real well in cells that are sparse. But as soon as they start to get close and start to touch, like they do in organoids, we're having some trouble. So we're running the CNNs and then adding more on top of that. But it's not perfect yet. So we're still relying on the Cell Profiler pipelines. Mm-hmm.
So moving on to some questions that we have about the culture conditions, is there selection pressure for the cells which grow out under the organoid conditions that you provide? And do all the cells in the tumor sample grow out?
Yeah, that's a super cool question because it actually speaks to one of the advantages of organoids. So what we find when we do like genetic hotspot sequencing on the organoids is that we have much cleaner data than we do from the original tumor sample. And that is because we do select for tumor cells within the culture rather than a large degree of stromal cells mostly is what we're keeping out just based on the culture conditions. And then further, what we're finding, I wish I had the image to show you, is that if you look at a plate of organoids and you look at, say, the redox ratio of them, you'll see some that are much lower than others, and you can actually pipette them out and then sequence those, and you'll find that those are the subclones. So it's a really cool way to be able to identify subclones and then actually isolate them and then ask how they differ. I think I answered the question. I kind of went off the rails there, yeah.
So we have, a few sort of clarification questions. When you perform the assays and treatments, do you keep the organoids or tumoroids within the ECM or remove them from the ECM?
Yes, we do remove them from the ECM and then we put them in a matrigel or collagen matrix, depending on the protocol. Most people are using matrigel, which I know isn't fantastic because batch to batch variation and it has all kinds of unknowns in it, but that's what is the current standard protocol. We do try to keep, with culture conditions, we can keep T cells in there. You just have to add cytokine. You can keep fibroblasts, I showed you, and other cell types will grow in there. You just have to have the right things in your media if you want those. Yeah.
Okay. So looks like we have time for one last question. How quickly can you scale the organoids from the time that you receive them from the patients to conducting these assays?
Right. So the time, I think we used to just get the biopsy and then within 3 days we would treat them almost immediately and then 2 days later assess treatment response. But working with some other collaborators, they prefer to passage the organoids, so they might wait 7 to 10 days before giving the drug and then assessing response. So again, it depends on what your goals are. If you want to retain more of the original tumor cells or if you want to select for those more pure populations.
Well, thank you very much, Melissa, for the talk and answering these questions, and thank you all for participating.
Yeah, fun stuff. Thank you.